Well, welcome. Tonight we have a veteran of the show coming on again this year to give us an update on what he's doing to keep our knees and other things working properly. Why don't we start with an introduction?
Sure. I'm Dr. Michael Vazquez. I'm an orthopedic surgeon. I have an office in Milford on Fortune Boulevard. I'm in a group with two other surgeons. We are all orthopedic specialists. My specific subspecialty is more arthroscopic surgery, sports medicine type injuries, but that really ranges from treating young kids to older adults to everything in between. And we also, my partners do quite a few joint replacement surgeries for hips, knees, and shoulders. And I've been at the practice for about 8 years now. The practice has been there. It's called Mulroy Orthopedics. Mulroy is the name of the senior partner, Dr. John Mulroy. And I think he's been in Milford for almost 15 years now, I believe. So we're pretty well entrenched in the community, and yeah, it's nice to be back. I think it was a couple years ago that I was here and kind of talked orthopedics and other things, so thanks for having me back.
When you think about it, I'm trying to think, my mom had her first knee done about 12 years ago at your practice, and then the second one a couple years later.
Unfortunately, that's not an uncommon occurrence with knees and other arthritic joints, where usually the wear and tear is fairly symmetric unless there was some major injury. People who need knee replacements over time, if it's one, then the next one may not be far behind. I tell that to a lot of my patients, where I see them for one knee and I ask them about the other knee and they say, wait, yeah, that's been starting a little bit. It's the way this one felt 5 years ago. And I say, all right, it's about 5 years behind.
That's about normal.
Yeah, that's pretty common. So, once you have one knee replacement, the other one may be coming, but again, it depends on the situation as well.
You talk about working with young adults, hopefully not many children, I'd hate to
Well, not for arthritis, but for injuries. Children are actually one of my favorite patients because they get better the quickest, and they get back to doing everything they want to do faster than adults usually.
But what takes up the majority, if you were to break down your activities in your office?
As far as the different
the demographic, old people like me, children.
Well, definitely the term old, I don't really use that.
Yeah, you can't. You have to be politically correct.
Right.
I don't have to.
Right. So I would say the majority of patients are between the ages of, that I see in my office, 30 and 50, probably. That's probably the majority of my patients. But again, I do see quite a few high schoolers and teenagers and even younger patients, and I actually really like taking care of those patients because it's usually always an injury and they're trying to get back to playing football or gymnastics or some kind of sport activity that they got injured in. I'm trying to get them back to. But just the way the demographics are, there's so many more 30 to 50-year-olds around that playing basketball for their, once a week, they'll come in with injuries, hockey once a week, all these, people are staying active and playing more, higher intensity sports and not just going on the treadmill or on the bike. They're playing intense sports.
And you're letting your children play hockey, even though you see old people like me. You haven't convinced them like badminton or...
Well, I was thinking about squash. That would be a good one. Yeah, my two oldest play hockey, and definitely worry about them as far as injuries, not just orthopedic, but also head injuries, which falls under sports medicine, although I don't treat head injuries. As a sports medicine physician, certainly that's one of the main injuries for the contact sports like hockey, football. And what's good is that that's gotten so much press recently, and people are very aware of it, which is the start of kind of treating and dealing with it. But yeah, I think hockey's a great sport. Actually, as far as jarring on the joints, it's not too bad because it's all the gliding. The problem is a lot in the hips with the goalies and the positions they get their hips into. I see a lot of hip problems in the goalies, but overall the knees, if they're not injured, that's usually a pretty good sport, actually.
So you got about 60%, 30 to 50-year-olds?
Yeah, I'd say so. Yeah,
and then like 10 and 30, or?
Yeah, I must say that most of my patients over the age of like 70 are usually from some kind of like injury, like a broken hip or broken ankle, fall, break their wrist, something that was more of a trauma.
Trauma versus...
Because my partners will do the replacements, and a lot of them that have had pain for several years fall into the replacement kind of category. So I don't see as many of those patients in that age group for just pain that's been going on for 10, 15 years.
So now when you do a subspecialty, you're saying you've got a couple of the physicians in the office who replace.
Yep.
And you've got you to treat. But are you treating hips, knees, hands?
So here's the thing. All three of us will treat many different kinds of patients. Myself and Dr. John Mulroy, when we finished our regular 6 years or 5 years of orthopedic training, we each did an extra year of training in specifically sports medicine. So Dr. John was down at in Miami doing a fellowship where he helped take care of a bunch of the like the Marlins and the Hurricanes, University of Miami. I think the Dolphins, but I'm not 100% on that. I spent a year doing sports medicine in New York, and I try not to say this too much, and maybe this came up last time, but I did help out with the Jets when I was there for a year, assisting the head team physician. And so we spend that whole year just really focusing on sports injuries.
Yeah, but you see, you can say things like the Mets and the Jets, because nobody cares.
Right.
If you use those other words, when you start talking about those Giants and the Yankees,
right.
That's when you get the emotion.
Yeah, although the Yankees not even so much anymore since we've kind of put them in the rearview mirror. But
This year.
But with the Giants beating us in those 2 Super Bowls, that's not...
Somehow that injury has never quite healed.
No, it hasn't. I was in New York that year, and there was a pretty miserable time because everyone was so happy around me, and I was miserable because I was, obviously, I grew up in Massachusetts and lifelong Patriots fan, so that was tough.
Now, what injuries take up most of your time?
So for sports medicine, most of the injuries are knee and shoulder, the ones that end up coming to see me. And in particular, the knee, because the knee, you get injuries in a full range of sports, from overuse injuries, like in running, cross country. I'll see, athletes come in with runner's knee, which is just a generic term for tendinitis around the knee that happens in a lot of runners. But then there's the flip side of the traumatic injuries that I see so much in cutting sports like basketball, soccer, football, ACL tears.
Yes, hello. But I mean, when I think of it, basketball seems to be a sport where more old men get hurt.
Oh yeah.
I don't think of it as full contact like hockey.
No.
But yet,
it's the non-contact injuries that are probably more of a problem. In basketball, for kind of older basketball, Achilles tendon tears. I play basketball usually about once a week, and I've seen a couple right there on the court where a guy's by himself, all of a sudden he falls to the ground, turns around, thinks that somebody hit him in the back of the leg. And it's just that when he pushed off, his tendon went bam, popped.
Just stretched too far?
Yeah,
or?
well, it's him pushing off really hard, whether he's not warmed up properly, or, it's hard to know because he's probably pushed off like that 100,000 times before, but that one time gets him. So I see that a lot. I mean, twice is enough to see, and then in my office I see it quite a bit, the non-contact. And then also the non-contact knee injuries are usually the problem too, where someone lands, twists, they feel a pop, maybe not, it swells up, they either tear a meniscus or injure their ligaments. So it's not even the contact sports. As we get older, we're probably a little bit smarter. We wanna stay healthy, so we minimize the bumping and banging underneath the hoop, but there's still those non-contact injuries you can't get around.
I can understand if I'm being silly and I don't warm up, I don't stretch.
Which is most people, but...
I was going to say, don't we all admit?
Right, yes, yeah.
You find that like on the ice, when we were younger, those first couple warm-up minutes, you were really flying as if mom was watching in the stands, or some young lady that you want to impress. As we got older, it seems to be less rigorous of a warm-up.
Yeah, and that's, I think, a big problem. But I think, and whether it's just being lazy, but most of the time I think it's the time. When you're going to play, you arrive there, you got, if it's hockey, you got 10 minutes, you throw all your stuff on, you're out, you're playing. Or the same thing with basketball, you just get your shoes on and it's time to play. it's really worth each individual's time to warm up. And I tell my patients and my friends and family that really, if you're going to be playing a hard, cutting sport where you're going really 100%, you want to, before you even do that, you want to have gotten a little bit of a sweat. So whether that means riding a bike, jogging, doing something where you actually start to feel, hey, I got a little bit of a sweat dripping. And then your muscles are warm and you can stretch out a little bit and then try and prevent the injury. Going in cold, it's bad.
So if I'm playing basketball, and this is new to me because I've never played basketball, how do I know? How do I learn? Everybody remembers their younger days when they were, the Kobe Bryants of the world,
yeah, sure.
at least in their mind.
They think so, yeah.
Right?
Yeah.
Okay, now you're hitting your 30, 40, 50 years old.
Yeah.
You got to be a little more sensitive because it's going to bite you sooner.
Well, yeah, definitely. But for each individual, I think it's different, and I don't think there's, a recipe for each person, but certainly being smart about it and knowing your own limits and building up to, say if you've never played or you don't play basketball, so, it wouldn't make sense for you to all of a sudden go join a pickup league where you're
right.
playing full court sprinting up and down, you start
But
by...
if I'm playing and I say, where do I go? Is there like a book to read that says, look, you have to adjust?
Yeah, that's a good question.
But start with, you said you should have a light sweat.
Yep.
Well, as you got my age, if they didn't have the air conditioning on in the locker room, some of those summer games, I'm sweating when I'm walking out.
That's good start.
Just putting my clothes on, my uniform. But is there a place to go and say, okay, if I'm 40 years old, here are basic warm-up drills. Is there anywhere that you know that you can go look?
That's a good, no, I don't have anything off the top of my head as where to go. In general, I tell my patients if you're going to look up something on the internet, whatever you type in, if it has to do with orthopedics, is you put the first 4 letters should be AAOS, and that's the American Academy of Orthopedic Surgeons.
Ah.
So if you put that in and then your search term, it's going to come up with, it should come up stuff from their website, which is going to be your best source.
But that's helpful. So if I start with an AAOS warm-up,
Yep.
or go on the AAOS website and say, drills for old men warming up.
Correct. You may find something, or just proper warm up, and they have tons of patient education stuff on there. And so I don't know if they specifically have here. This is what you got to do, but they'll probably have.
Any protocol they put out has to be adjusted.
Well, that's what I mean. That's for individuals, but also they are they're up to date. Obviously, it's that's the society that kind of runs the orthopedics as far as what is proper to do, what has evidence to do, because you could a doctor could do a lot of different approaches, but the academy kind of outlines things the way that through studies that they've optimized.
Big issue hamstring, stretch them out.
Yes. Yep.
Get them warm and stretched out before you get on the court and start doing your fancy shots that put strain. And
one of the kind of the key terms is before the workout is dynamic stretches. So the two differences, there's dynamic and static stretching. Static stretching is like the old school kind of, you just bend down, like hold, trying to touch your toes, and you hold that for 10 seconds and then you're done. I really don't feel like that's the best way because your muscles may not be warm enough to really get a stretch like that. So dynamic stretching adds movement to stretches, so like doing like high kicks. So if you ever watch like the NFL players when they come out on the field early, you'll see them do these simple, they'll all be in these stacked lines, and they'll do some kind of form stretch. So like high kicks as they walk down the line, or like a quad stretch as they walk down. They'll do dynamic stretching, so they're moving and stretching at the same time, unlike the just stretch and hold of a static stretch. That should be at the end of the workout. But those are things you could type in, dynamic stretching, AOS, and you probably find stuff.
Now, when it comes to ACLs, I can say from experience that I was warm. It was second period, so by then I was fine, and it was weird. I just went to cut in front of the net, And it was like somebody took a little knife
Yeah.
and stuck it in the side of my knee.
Yep.
And then the knee got big.
Yeah.
What did I do wrong here?
So, and you bring up a great point, because most of the ACL tears are non-contact, and it really is something that usually the athlete has done hundreds of times before. Like, it's nothing.
No, I
that's
crossed
not-
over in front of the net, yes.
It wasn't a different move, and why did it happen on that time? I won't be able to answer that for you individually, but what happens is when you're, no matter how warm you are, which is good, if you have a sharp enough turn or pivot or stop, and with blades, did you just get them sharpened or anything like that? Because that would be a risk factor, I think, for injuring your ACL that way, if you had really sharp skates and you dug in.
But if I don't sharpen them, then I risk injuring my ego because I go
Sure,
splat.
sure. Well, that's what's interesting. And just like in football with fields, there was one study that showed that if it's a wet field that's slippery, you're less likely to tear your ACL because your foot won't plant and put the energy through the knee.
Well,
It'll
wasn't
just
that
slide.
the whole AstroTurf, that the shoes got so much better at holding you in place?
Yep, yep.
And you sat there and said, okay, if the shoe holds and the body turns,
That's exactly right. Something's got to give.
something's going to give in the middle.
Something's got to give. So it's ankle sometimes, or the
Or
knee,
knee.
or the knee, and that's a common way that injures. So yours was probably in some way either you said you stopped,
I just cut over. I
You're
mean, it
just
was like-
cutting.
I
Yeah.
think in the
Yeah.
middle of a game, you're not thinking.
Yeah, and once that ACL tears, it bleeds and it fills up the knee with blood, and that's why it got swollen so fast. Literally, it bleeds, and there's definitely different. I don't want to say degrees. I mean, it's kind of the ACL is either torn or not, but there's degrees of injuries. Like if you remember Gronkowski's injury, how his knee looked like it went just way too far in the wrong direction with the amount of force that guy hit him with. I think he also tore his MCL. He had other ligament injuries, as opposed to. There was a few years ago when, for the Celtics, Rajon Rondo was playing for the Celtics. He tore his ACL on a play that he just like jumped up, landed, kind of grabbed his knees. Probably more like the way you did yours, where you're like, wait, what
Something's
did I
weird.
do here? Something's weird, and he ended up with a
But
torn ACL.
you could feel. I mean, when I took off
Oh,
my
yeah.
shin guard,
Yeah,
all
that
of a
was blood.
sudden
It was bleeding into the knee.
So is
Yep.
it the blood vessels into the?
Yep, in the ACL. So when it tears, then the blood vessel that goes through, that feeds the ACL, gets
Just
injured
is
as
wide
well.
open and-
Yep.
Because I remember you had to stick a harpoon in my leg.
Don't,
And-
you're going to scare the audience.
No, but from a physician's point, it was a 30 ml syringe, I think, a small needle.
Yeah.
I never really thought of that type of syringe
Mm-hmm.
as a harpoon till I saw it entering my knee,
Right. That's a little
And-
different when it's your own body. Yeah.
and you took two of those out of there.
Yep.
So
That's
now-
not uncommon. Yeah.
Is that right?
Yeah, and I think that got you to feel better because the pressure was down.
The pressure was off. It
Yeah.
felt so much better right away.
Yeah, and that actually helps with the diagnosis, because as you take it off, you can see, is it filled with blood, is it filled with yellow fluid, or a mixture of the two, and that can give you an idea of the injury as well, and helps to examine the patient too.
Yellow fluid
Yep.
versus red fluid,
Yeah, well, red would be blood,
right?
and yellowish fluid is just what your knee joint makes naturally a little bit. So.
Aren't I supposed to have synovial fluid there?
Yeah, but just a little bit of synovial
Oh.
fluid though. So in a normal knee, there shouldn't really be enough fluid to pull out.
Like 6 or 7 mils?
Not
maybe?
even.
Really?
Like, it won't even really pool. Just kind of line the
Well, that
cartilage.
was always the problem when we wanted to develop assays,
Mm-hmm.
for synovial fluid markers.
Yeah.
You never could get enough.
Well, yeah, that is true. On a normal knee, you're not going to find it. It's got to be irritated knee. And once it starts to pool in the knee, that's abnormal. So when I examine a patient, usually I can tell if there's pooling in the knee. And that's when you'll actually be able to draw out some fluid. And that would be
so
yellowish.
if you pull out blood or reddish fluid,
Yeah.
then you're sitting there saying, okay,
There was an injury.
It was
Yeah,
an injury.
Yeah, the only way that would bleed in there is something got injured. Now, it's not always an ACL. I've had patients with bad arthritis in their knee that have had a somewhat innocuous injury, and then their knee fills up with blood. And they, who knows exactly what they injured, but a little blood vessel got injured from whatever they did and filled up the knee with blood, and that can be quite painful,
So
having
now,
your knee filled.
the ACL doesn't always tear through, right?
Correct, that's
So
correct.
I could get a
You get
partial
partial
tear,
tear, yep.
and then is it a regenerative?
No,
organ?
that's a good question. That's the problem with the ACL. That's why we do so many surgeries on it, is because if it leads the patient to have instability, meaning their knees giving out on them, the body doesn't heal it. And it's because it's sitting in the middle of the knee surrounded by this fluid, as opposed to the other ligament that's commonly injured, the MCL on the inside. That has a very good potential to heal because it's not in the joint. It's kind of between the joint and the skin. So when it tears, it still kind of stays like this and then heals together. Whereas once the ACL tears, fluid goes between it and
And you're done.
it just can't heal
But
back.
I guess my question is, if my ACL, okay, in this case, I've got 4 fingers worth of ACL.
Yep,
If I lose 2 of them,
yep, yep.
these don't come back.
Probably not.
So
no.
now I have a weaker ACL,
Yep.
and if I continue doing what I'm doing,
You could have, you could
the odds are
injure it.
pretty good that now 2 fingers
Yeah.
are trying to hold what 4 fingers were designed to hold.
Yep. I've seen that a couple times in patients who have injured their knee and they kind of feel like they maybe did something, but it doesn't swell up with fluid. And I think they have a partial tear, and then they try and get back to playing basketball, and then it really gives out. And whatever they had left went, and they now have
So
it
now
completely
once
torn.
it's torn, so I got 2 pieces flapping in the
Yep.
wind, body reabsorbs it?
Yeah, yep. So over time, it would reabsorb it. So when I go in on surgery, if it's within the past 6 months, usually I can see the ends. And sometimes it won't tear right in the middle. Sometimes it'll tear off the bone, but I'll see both ends. But I did a surgery on someone who had torn their ACL like 6 or 7 years earlier, and they just for whatever in their life they couldn't get it fixed. But they finally had surgery. There was like nothing there.
So now
it's just nothing.
I've got nothing there, and I understand you can go carve part of my body up to make a fake one,
Yep.
or
yep.
you can go kill somebody and get a cadaveric one.
Correct. Yes. Yes.
Yeah, I
Yep.
always said if I'm going to do it, go kill a young one.
Well,
because I
that's-
want
you're-
one young man's. I got enough old men's body parts.
Right.
I want one young man.
Well, that's right. You have it right. Those are the 2 choices. Right now, we don't repair it, we reconstruct it. So we actually take a tendon, not a ligament, a tendon, either from the patient's body, your own body, or from a cadaver, a donated tendon. And there are pluses and minuses to both. A lot of it depends on age and what you're trying to get back to doing. The younger the patient, if they're in their teenagers or young 20s, and they're trying to get back to high-level cutting sports, I always take their tendon. There's good evidence that that's the best thing for them, is to take their own. Once you get into like 35, 40, and depends on what the circumstances are. So if you just like stepped off a curb and tore your ACL, but otherwise you're a couch potato, well then I would, even if you were 30, I would just probably take the cadaver tendon and say, we don't need to use your own and create this collateral injury.
What
Yep.
tendon are you carving up?
Yep.
I mean, initially, my visceral reaction
Yeah.
is, wait a minute, I
Take
got a
someone
problem
else's.
here.
Yeah,
Now you're going to go carve up and make a problem on a working part?
that's right. But you're right, that doesn't make sense. So it's not the best for everybody.
But which tendon would you take?
So there are 2 main tendons that I take, but there are a few other ones that other surgeons will take. The kneecap tendon, the patella tendon, it's about 3 centimeters wide in most people. So we take the middle third, so the middle 10 millimeters or 1 centimeter of tendon with a chunk of bone from the kneecap and a chunk of bone from the tibia here and remove it. So now we have a little
So you
piece
got
of
the
bone.
anchors.
The bone, yeah, the bone on both sides serve as the anchor points, and we thread it back up to where it belongs and put screws in where those 2 little pieces are to hold it in place. And the bone-to-bone healing is very good healing. That's the way when you break a bone, you heal bone to
Right.
bone. So if you take your own tendon, you'll get quicker healing. It's and if you're 18 years old, you're not going to find, which is a good thing, a dead person's 18, someone younger. So
But you're not going to get an immunological response either, right?
correct. Either way, you don't get an immunological response, even on the cadaver tendon, because there's no live components to that tendon. So you know what I mean? So once it's taken out,
Really?
any of the cells, yes, so that gets all cleaned out, washed out. If it's your own, well, it has your own stuff in
Well,
it, but that's
that
okay.
you don't worry about.
Yeah, that you don't
but
worry
I always
about.
worried about a cadaveric implant saying, okay, the body's going to wake up,
Yep.
call up to the spleen and say, that's a foreigner.
Yeah.
Go get it.
No, but it's different than like we call a living or like a heart or lungs,
Right.
where we worry about rejection, and that's a huge problem. You don't need to be matched to get the cadaver tendon. I've never seen a full-on rejection. I don't think that's really described, but there are some people who have seen kind of mild rejection where your body, even though it doesn't treat it as completely foreign, it has a little bit of a reaction to it. And
So I don't have to worry about like a foreign body reaction or anything.
well, a little bit, but that's rare.
Okay.
Yeah. I mean, but certainly one of the things that we think of as, when you talk about the plus minuses, that would be one of the things.
Do you
you'd
get
say
to
is a
order
possibility.
the cadaveric, like older, younger?
Yeah, not specifically. You don't always have your exact choice, but yeah, if in particular, if I've got a patient who's 33 years old that is having the surgery and we plan to use the cadaver tendon, I'd like to have a tendon that's 33 years old or younger for them.
You don't want a 60 or 70-year-old.
No. No offense to them, and it may be a fine tendon, but it's just that person. It makes kind of just intuitive sense. That tendon is 30 years old, or that person's 30 years old.
But do the tendons get stretched? Do they get used?
Well, tendons do wear down over time, so people, depends on different tendons through your body. So yeah, I mean, I guess
So
the
how
short
do you
answer
know
is yes.
you're getting a Class A tendon versus, this guy was a couch potato?
Yeah, you don't really know, but there's also in the literature, there's nothing that there have been no studies that have really characterized. Okay, if the tendon is this old or older, it's not good. So that's more of just kind of using, I guess, in a way, common sense and just.
No, but I think about different tissue repositories. One of the big areas now are trying to regenerate lungs, hearts, kidneys that are borderline for transplant. And there are criteria where, okay, you can look at lungs of a heavy smoker and say, no, not going to accept it.
Right. Sure.
So there's acceptance criteria in the banking.
That's a good point.
Arena.
Yep. But and I may not have the full info on it, but my understanding is that is for the orthopedic kind of tendons. It's more of does someone have risk factors for infections like hepatitis C
Right.
or anything like that, and then they just get immediately.
Taken
if
off.
someone has risk factors or was diagnosed with that, they're not a donor.
Well, any live tissue or not so live tissue
Yep.
that's been exposed to Hep C or something,
No.
you're just going to disallow.
No,
use.
right, exactly. And even you worry about everything, HIV, Hep C, any of the viruses that can kind of stay alive in there. And the risk is not zero. That's one of the things I got to talk to my patients is that when they get a cadaver tendon, it's extremely small, but not zero of transmission of those.
Yes. Good news is that 99% of the people will survive. The bad news is you're the 1%.
You're the 1%, right? Well, that's why I always tell my patients as I'm going through the list of all the things that can happen. I say, the surgery works very well, and these, rarely happen. But unfortunately, there's, it does happen, 1% or 0.5% of the time. And when you do enough of the surgeries, unfortunately, you see it, and you want everyone to be informed as much as they can be.
So now you mentioned tearing the meniscus, which again, bingo, I get 2 points.
Yep. We could have a whole show just on your knees, I
It's
think.
just on my knee. It'd be a look in the dictionary for bad knee. You'll see a picture of my knee. But why do I tear a meniscus? What is a meniscus?
Yeah, meniscus is a piece of cartilage in your knee, and that's most of the time when someone says, "Oh, I tore my knee cartilage," that's what they're talking about is their meniscus. That's the kind of a layperson's meniscus. It's a cushion in the knee. You've got two, one on each side of the knee, medial and lateral, and it really is. It does multiple things, but kind of the best way to think about it, I think, is as a cushion to the knee, and it protects the rest of the cartilage from arthritis. And so we know if you remove that meniscus completely, there's much increased pressure on the rest of the cartilage in that area, and you'll go on to arthritis. So 30 years ago, if someone had a tear in the meniscus and it was causing problems, that or 40 years ago before arthroscopic surgery, they'd have an incision, crank open the knee, and just cut the whole meniscus out. And people would do fine for the next 5, 6, 7 years, 10 years, and then all of a sudden they'd say, "Oh, my knee's starting to hurt here," and you see that they've got bone-on-bone arthritis because that cushion's gone. So now with meniscus tears, and this is nothing new, this is for many years, we try and keep as much of the meniscus as possible and even avoid operating on it if we don't think that it's going to be, the fix for somebody. In other words, if you have also arthritis in the knee and a meniscus tear, you could go and fix the meniscus and have the patient say, this still hurts me, and it's the arthritis. So what have you really done? Nothing. You've just taken out more meniscus. So we're a little more conservative, I think, about chopping it out, and but it can still be quite symptomatic, meaning people get a lot of pain, catching, locking. It's still one of the more common surgeries that an orthopedic surgeon will do.
So we get back to my knee for point number 3.
Yep.
I have a lazy meniscus because it let the arthritis in.
That's right, yeah.
Now, you hear arthritis, and you hear OA, RA, rheumatoid, osteo. What is arthritis?
Yes. Arthritis simply is just the wearing down of the lining cartilage in any joint. Okay, so I tell my patients to think about, most have had chicken wings or chicken, fried chicken. So you see the end of the bone, it's got that rubbery stuff.
Right.
That's cartilage. That's essentially what everyone's cartilage looks like. It's a rubbery kind of material that is at the end of the joints. Knees, hips, everywhere, the fingers, you got tons of joints in your spine. I mean, they're all over the place. So arthritis is simply the wearing down of that cartilage. And then you had a good question about osteoarthritis versus these other kind of arthritises. And we talk about two major categories: the osteoarthritis, which is what most people have problems with, and that we kind of say wear and tear. If you live long enough, you're going to get arthritis in some
You're going to get OA no matter.
You're going to get it somewhere. Yep,
Right.
yep.
It's kind of like diabetes, where they say if you live to 120, you're going to get it.
Yeah, but even more so with the arthritis. So, if you get x-rays of people's bodies, even someone who doesn't complain of any pain, someone in their, 50s, 60s will have arthritis maybe in their shoulder or in their hand. You'll be able to see it.
But when you say you can see it,
yeah.
okay. So I go to your office.
Yeah.
The first thing they do is send me across the room
Yep, for the
to
x-ray.
go get nuked.
No, you're okay.
I go in there. I walked in. I said, medium well, please. Nothing more. But what are they? I think of an X-ray. I think of them looking at bone.
Yes. So, good question, because that is really what the X-ray shows: is the bone, a little bit of the soft tissue, as far as basically see if there's a lot of swelling of the skin, but it doesn't show anything specific with the cartilage, ligaments, tendons. But the reason why we get those all the time, and in particular when we look for arthritis in the knee, we get those X-rays with you standing up, okay? Because when you stand up, the pressure through your femur bone into your tibia bone will collapse the space of where the knee bends, okay? And when somebody has arthritis, it means the cartilage in between there has worn down. So those bones will look closer together.
They're almost touching.
Yeah, or if it's severe arthritis, no cartilage, you will see bone sitting on bone. Whereas if you get the X-ray lying down without gravity, without their weight through it, it may just be sprung in a position that looks okay.
So OA really is an active issue. It's not people think of osteo. They think of OA as there's something being deposited in the knee joint. It really,
it's not.
It's the lack of that cushion.
That's right. It's the lack of that cushion, that lining cartilage, and I get that all the time. It's like, can't you go in and scrape it out, scrape out the arthritis? And no, that's the last thing you want to do. You want to leave whatever cartilage you have still there in place. So whenever we do surgeries and there is some arthritis, if there's flakes of cartilage hanging there, they're not doing any good. So I will just remove those so they don't break off and float around the joint.
I think the layman too many times thinks it's some kind of coating.
Yeah.
Because it hurts.
Yeah.
So it's a sharp, almost like a rust.
You're right. It's exactly the
get
opposite.
in there and scoop it out.
It's the lack of the cartilage.
Okay. So now in today's technology, when my eyes went bad, they went in and they blasted the lens and they put a new one in. Can't you just make a fake?
We can, except it's not alive yet. Meaning it's the knee replacement. So still the state of the art right now, still for severe arthritis in the knee, is for sure a knee replacement.
When my mom, she could barely walk because the X-ray showed there was no space. There was bone on bone, and every time she moved, the two bones hurt.
And scraped,
They went in and they replaced the whole knee.
That's right.
There's no way of just replacing the cartilage like a little disc?
No, not yet. Not yet. I mean, those are things that, if that can be figured out, that would be fantastic. Because right now with knee replacements, you do remove a good portion of the patient's bone at the ends of the knee, because you're not just removing what's left of the cartilage, but also some of the bone. And you're literally putting metal and plastic together. And so
Well, you need to anchor it somehow. I don't want it
anchor
coming loose.
usually with cement. Most surgeons will use cement. But it's metal and plastic, and just like anything mechanical wears, that can wear down too. That's one of the problems with cartilage as well, is that when it wears down, it doesn't heal itself. So, like if you strain your muscle, I mean, that will heal and you get your muscle back. If you injure your cartilage, it may stop hurting you, but it hasn't fixed that divot, or it hasn't really repaired itself. And I think if that's one of the things through, future breakthroughs would be to be able to get that cartilage to heal itself once we know that it starts to wear down. So a lot of the research is looking into, forget about when you come into my office and you can see on the x-ray it's worn down. How do we find the patients that you can't see on the x-ray that they've started the arthritic process, and how do we stop it then before it actually wears down?
So what is this thing I hear about injections in the knees?
It's
cortisone?
Cortisone, yep. Cortisone is just an anti-inflammatory. We use it quite a bit to get people to feel better. And I spend a good amount of time telling my patients this does not cure arthritis. If they're getting it for arthritis. No, it's
no, what I'm saying
same
is,
same idea.
If
sure.
I'm feeling bad, I take 2 aspirin.
Yep.
I feel better.
Yep.
But I haven't dealt with the root cause of the issue.
Correct. In arthritis, though. So there are other problems, areas of inflammation that I'll give cortisone in for things like bursitis that can really actually just take care of it, and it can actually be gone.
So bursitis is?
Bursitis is inflammation of a bursa sac, and I see that quite a bit in the shoulder. And so I do quite a few injections in the shoulder where people come in with severe pain, and I'll give them the injection. I'll see them like a year later for their knee, and I'll say, how's the shoulder? They're like, oh, ever since that injection, it's been fine. Well, the injection doesn't last for a year. It lasts for six weeks. But what it does is it decreases the inflammation. Once it decreased the inflammation in that bursa sac, it just didn't come back because there was nothing provoking it. Unlike arthritis,
or you've modified your behavior that.
Or yeah, exactly. There might be something else, right? But you got it. But something that it hasn't re-aggravated. Whereas knee arthritis, I'll tell someone, this is definitely temporary. At some point, it's going to come back, but hopefully we can get you some relief and get you, either starting an exercise program or something that's going to benefit the rest of the knee.
So we heard osteo, and then you said other arthritis.
Yep. And those fall under kind of another big group called inflammatory arthritis, and there's a bunch of different kinds. There's rheumatoid arthritis.
Which the RA is what you hear about.
Yep.
The next.
Yep, there's something called psoriatic arthritis. People who have psoriasis sometimes can get problems with their joints.
Is that genetic or?
So, yes.
Well, how do I get rheumatoid arthritis?
Yeah, I mean, there is a genetic component to it, but there's also patients who have no family members that have had it, so that's not the only thing.
But it's not an active thing that I've been playing basketball or
no,
hockey.
No, that's
OA I can see.
Yes, you got it. Yep.
RA,
no.
Some either genetic or environmental factors.
Yep. It's your own body attacking your cartilage is what it is. So
like an autoimmune.
Yes, environmental, something that interacts with your genetics are susceptible to it. There's probably, some other underlying.
So now I go on the internet, and somewhere at some obscure university in a mouse, they've done a study, and I read how it's cured.
Yeah.
So I come back to you and say, why can't you do that?
Yeah.
They cured a mouse.
Yeah. I get that once in a while. Yeah, that's one of the, we think of all the new kind of techniques that come out, but even the newest kind of way that we do the ACL reconstructions now have really been around now for about 10 years. So even though people think like, oh, that's, the new way the NFL players get their ACL reconstructions, the same way that I do it, the same way that, most sports medicine orthopedists will do it, and we've been doing that way for about 10 years. But in order to get that kind of innovation of something that's going to be used in a human that works well on an experimental level, I mean, it's years and years.
Well, isn't that the whole purpose of clinical trials?
Correct. You got clinical trials that, like, it starts with animal models, and they just want to see, is it even safe for humans? Never mind, does it work? And then obviously, does it work is the next thing. So,
and do I want to be the first one to find out it worked on a rodent, but not on me?
Right. Not me, but it can be very exciting and I think for both the physician, who's doing these trials, because hey, this could be something great. But as a practicing orthopedic surgeon, I've got to make sure that this has gone through all those levels and that it's tried and true before I want to introduce it into my community practice.
You put it in perspective when you said you can continue to play hockey, and all you're going to do is accelerate the wear. Eventually, you will need a new knee. It's just how long you want to wait. I mean, I could see if it's an oncology question. We've tried everything. You got 3 to 6 months.
Right.
Okay.
I'll do anything.
Let me go try. I want to make it to my daughter's wedding or whatever.
And they are more likely in those kind of cancer kind of therapy treatments. They open those up so that, those don't have to go through quite the same proof in order to go through trials, because what's at stake is people's lives.
Yes. And when door number 1 is death. Door number 2, not a problem. I'll take a risk.
Whatever it is.
When door number 1 is you're going to skate slower or you've got to change. Oh, okay. Maybe, I'm not worried as much about door number 2.
Correct.
So now, knee replacement. I mean, when I first heard of that, I'm thinking they're taking a chainsaw and cutting out part of my mother and putting it back.
Unfortunately, that's not that far away from it. I mean, obviously we're a little more precise with how we cut, and but it's that same idea. It's literally just
you're shaving the top and the bottom of both, and then sliding this
and
metal.
Then under the kneecap, getting rid of the cartilage under the kneecap, putting a little plastic button under there, and then the and they're sized, so you get, it's not just like 3 sizes. There's many different sizes, and so we're very good at matching people's, the way their physical body is.
3 weeks after, she's up and walking and not screaming every time she walks.
It's fantastic. The people that have bad arthritis that get knee replacements, I'm not going to sugarcoat it. Yeah, it hurts to have the surgery, and I'm sure your mom would tell us that, but it's usually a different pain. The arthritis pain, they can tell, is gone, and now it's surgical pain, and you can see the light at the end of the tunnel and saying, wow, this is already different. I know it's still killing me right now, but this is different. This is someone cut my leg open, but that's going to get better, and it does. And so, the results from knee replacements have just, changed many people's lives.
It's amazing. So now we move from the knee. What's the next common, shoulders or hips?
Shoulder. In my practice, shoulders, especially for throwing athletes, but also just, go forget about athletes that are playing sports, just, everyday kind of injuries, people lifting something that's too heavy for them, or falling, landing. A common one is falling, trying to grab onto something to support their body, and all the force goes through their shoulder that is not ready to support their 250 pounds that they're trying to hold. So I see
Don't look at me when you say that.
No, I would have said,
I'm
205.
I wish it was 205. I'm too close to that.
So
it's a stretching.
Yeah, stretching or overuse with the shoulder. A lot of people that are trying to either at work, they've got repetitive overhead things, or they like to do exercise. So the shoulder is just a common site for injury and kind of overuse inflammation pain. And there's different reasons for it, but one thing is the shoulder has got such a great range of motion, so that in order to have that range of motion, you sacrifice a little bit of stability. So I see a lot of patients that come in with their shoulders that have been dislocated, and that oftentimes happens from football, basketball, hockey, even sports, but also just from falls, and they land on it and the shoulder pops out of place. And so that can be a major problem, needless to say.
Now on TV, they hit a wall and they're manly and it pops right back. What's reality?
No, the reality is the first time that happens, 95% of people have to go to the emergency room because the ball is out of the socket.
Right.
And all the muscles spasm around the shoulder, and they do not want to be touched, and you're not going to hit this against the wall. Now, there are patients that I've had that I've seen that say over the past 10 years their shoulder comes out once every 6 months. And so they don't go to the emergency room after the first time or the second time. They figure out how they pop it back in, and they pop it back in themselves.
But can't they do more harm?
Yes, you can.
I was going to say, for the love of God,
Yeah.
I mean, I'm a manly man. I
Right.
can do it myself like Mel Gibson on TV, right?
Right.
If
Yeah.
I do it wrong,
Well, it's not so much doing it wrong. It's more of you shouldn't let this happen over and over again. You know what I mean? It's like, I got to say, the way we pop it in is there are different techniques for it, and certainly even by yourself, you could actually reproduce one of those techniques. I'm not going to do a how-to guide on that
please.
for anybody. But the long story short is that it shouldn't just be doing that, and you could be damaging the cartilage every time that happens.
the only way that makes sense to me to reset it is 911.
Right. Well, I think most people, that's what makes a lot of sense too. And so once you're in the ER, usually they'll give you a little bit of sedation, like propofol, something that'll basically knock you out, at least not have you feeling any pain. And then usually it's pretty easy to locate the shoulder. Once the muscles relax, it's not difficult.
You've done it more than once.
Yeah.
And you know how to relax the muscles.
Right, yes.
When I'm sitting, because I just fell, the muscles are not relaxed.
Correct. That's exactly right. That's the biggest problem. If you can get rid of that spasm, you'll be all set. And the only way to do that is by good medication.
Now, are there shoulder replacements? Or?
Yep, they're shoulder replacements. Those are not nearly as common as the knee and hip, probably because they're not weight-bearing joints, right? Nobody walks on their shoulder.
The shoulder?
What, the ball and socket.
Really?
Yep. And so those probably, still a lot of osteoarthritis for that, but also the rheumatoid and psoriatic arthritis, the other ones, because again, it's not weight-bearing. Most people can get around pretty well even with pretty severe shoulder arthritis because they use their other arm to reach for stuff,
right.
and they just modify.
Compensate.
They compensate. They modify what they want to do. But certainly, if the pain gets bad enough, and that can work quite well.
And except being a pitcher for a baseball team where you're
right,
or having a position, a job where you're constantly doing the same repetitive motion, there's really not much.
Well, right, as far as what
warm up before you play basketball, it's like,
Yeah. No, that's the thing with the I think that big difference between whenever someone has a lower extremity problem, they're limping and it's just an issue getting around. With the shoulder, people compensate, but yet I think it's the people that are looking to do more. It's the ones that come in. I've got, I don't think he'd care. My father-in-law's got terrible arthritis. He's a hockey player. He played, up until he was 70, essentially. But he can't lift his arm up above shoulder height. But yet, with the hockey stick and the golf club, he can still
you can
do it.
Well, especially at that age, they don't let you take big slap shots anyway, so you can pretend that it's okay.
Yeah. So for him, he's like, it hurts once in a while, but I'm not gonna. I don't need a surgery. Whereas I've got other patients that every day they need pain medicine. It's killing them, and they're the ones that do very well with the shoulder replacement.
And that's a scary thing now when you say the pain medicine, because the opioid crisis. We've had a number of shows where, you always thought of the heroin addict as this creepy person in the inner city down a dark alley. And then you find so many of them now are your friend's son, daughter.
Yeah, it's a big issue, and it's a big issue for any doctor that prescribes the medications, because it's pretty well documented that that's how a lot of patients unfortunately start on that road, is from pain medication. And so I am very conservative with the pain medication I give. Usually it's only after a severe injury and after surgery. And even then I spend a lot of time with my patients trying to explain to them, look, you want to be taking ibuprofen, Tylenol, those medications, and if it's so bad that you are up, you can't sleep, and you're just sitting there and it's just too much, then here's this more powerful medication that you take. But as soon as you don't need that, you stop that. Because I think one of the problems is, just the communication. Patients will get a prescription and it will say, 20 pills of, whatever, Vicodin, Percocet, the common pain medications, take every 4 hours as needed for pain. Well, no one's really sat there and explained to them what that means as needed for pain. That doesn't mean, oh, I feel a little something. Let me take something.
Let me take one.
Exactly. And then people say, I'll see somebody, and this was more in my earlier, when I first started, because I don't think I was as good as talking to my patients about it. They come in and I'd say, the first post-op visit, and they'd say, oh, I went through all the pain medication. And I was like, did you, really, was it that bad? You're like, no, but it's, you gave me 20, so I just took 20.
Did it.
And so I think a lot of patients would just think, oh, I got this from a doctor, I need to take it.
You're telling me 4 times a day?
Exactly.
I believe you.
And so now I think it's a lot of patient education of trying to explain that. And I think that works, and that's not a foolproof way, but I think that's for sure the best start to it.
You also hear how many parents, without knowing, you went through, okay, I had this problem, you gave me the pills, I never really used them, or I did what you're telling me.
Yeah.
The once or twice that it really hurt, I took the La pills.
Yeah, and that's
then
what
I
it's
put them
for.
in my medicine cabinet and I forgot them.
Yeah.
And then you
That's
find out
another
the
problem.
kids are hitting your medicine cabinet.
Yeah.
I mean, I was really happy when I heard that our chief, Tom O'Laughlin, set up in the police station a place where you can take,
Return it.
no questions, walk in with any drug you want.
Yeah.
The police aren't looking at you.
Right.
They refuse to even think about it.
Yeah.
And you get to throw them away.
That's great. Yeah.
So at least people are starting to understand that you could be part of the problem without knowing.
Yeah. Yeah, and that's the thing. And that's why I guess I just harp on that education part of it. That's just being aware of it and talking to patients about it, and then just having things like that where there's things you can do to minimize that risk, because it will always be there, but certainly we want to try and minimize that. And that's why I think with pain management, unfortunately there was a big swing, maybe about 15 years ago when I was in training in the hospital, where they talked about pain being the 5th vital sign. And so there was such an attention put on pain, trying to have patients not in pain, that I think we kind of overdid it.
You had a whole company, Purdue, that was touted as the saviors, pain management.
Yeah.
And now all of a sudden, Oxy, I'm amazed.
Yeah. Yeah, I mean, it's just, I think it's really flipped around, and because, pain, you don't want to be in severe pain, but pain is obviously, a normal, body response to things.
Your body creates pain to let you know I'm not happy.
It lets you know some things, and sometimes it's overboard and, we want to control, and other times it's like if someone breaks their ankle and they're telling me they're taking a bunch of pain medicine, I'm telling them, you're doing too much. Rest it, elevate it up. You shouldn't be taking all this pain medication because it hurts. But then that also goes to just the kind of the daily stresses of, I got to go back to work, I got to do this, it's killing me. And so, I see where it runs into problems, and I think being aware is number one.
If I've got pain in the ankle, what am I doing to cause the pain? Can I minimize it?
Yes, that's right. And I think people think of pills as the first way to minimize it, as opposed to...
You're back to aspirin. I can dull the pain, but your body's telling you what you're doing is not making me happy.
Yeah.
Please stop.
Yeah. And listening to it, is usually the better thing, for sure.
So now, except being a goalie with hip problems, I can see, they look like an arachnid gone wild sometimes. But what else would cause my hip? Not from a rheumatoid arthritic point of view, but from an OA, a trauma.
Yeah.
What do I do to cause my hips to fail?
Well, again, it's tough, because when hips wear down, like you said, there can be a list of different possibilities. One of the things, just genetics, is how your parents' hips, and they say, oh, my mom had a hip replacement or whatever. So there's definitely, even for osteoarthritis, there is a genetic component. There's no doubt about it.
But when I think of the hips, okay, my rotundness probably puts an extra strain on my hips.
Well, and the knees.
And the knees, but besides, losing weight, what else can I do to protect my hips?
Yep. So the two basic things, and this is when we send people to physical therapy for hip arthritis or knee arthritis, and that gets me into physical therapy, because a lot of people just kind of frown on that. They're like, that's not going to work. But the main things are really is to keep the flexibility as good as it can be, because when you have an arthritic joint, the joint tends to lose flexibility. And then it also, you tend to get weakness around the joint. And the stronger the muscles around the joint, we kind of think of the less pressure that joint sees, and hence the less pain. So physical therapy is a tried and true way of treating arthritis that is obviously non-invasive, but it's work. You got to do those things. And certainly it's not for everybody, because sometimes it will cause it to flare up more. But that's the idea behind, like, if you say, well, what can I do for my hip? It's keeping the flexibility, keeping the strength. And if there's certain positions that do seem to bother it, obviously avoiding that. There's a lot of people with hip problems who, if they sit for a long time, it starts to hurt them. And that may be because the head and the socket is kind of pinching, and if it stays there for a long time, it just starts to hurt. So they're better off doing things like the recumbent bike, things where their hips are not flexed up all the way like this. So just being aware of what things bother your hip, and avoiding them or
And again,
tailoring
those
it.
first 4 letters that you recommend on my Google search.
AAOS,
So
American Academy of Orthopedic Surgeons.
So the AAOS,
Yep.
get on that website
Yep.
and then look and say,
Yep, you can search, and they've got a
old
bunch
man with bad hips, what do I do?
You may have to be a little more specific, but you could put hips, certainly,
Well, I would think if you
arthritis
put,
for hips.
hips,
Yep.
arthritis,
Oh yeah, yep.
and then you can just kind of navigate around there.
Yep. And it can be a good resource, and I use that to my patients. I'll tell them because the internet is a great resource, but there's so many different things you can see, and so that's just one way that I know this is going to be good information for them.
Well, let's face it. You went to school until you're almost ready to retire.
Yeah.
With all, that always amazes me, between med school, the specialty, the subspecialty. It's like, when you get out, do you have to retire right away?
Yeah,
Or?
pretty much. You start planning for it anyways.
But you sit there and say, okay, so in half an hour, I've become a surgeon, because I can look up and educate myself.
Right. And certainly I find myself sometimes having to bite my lip when someone comes in and says, so what's going on? And they give me the diagnosis. I'm really looking for, where does it hurt? When did it start? And I say, okay, all right, that might be it, but tell me a little bit more about what it feels like, and those kind of things. So, it doesn't. I think I'd rather have an informed patient or someone that's interested and is looking into it, as opposed to someone that's just not.
It hurts.
Yeah, it hurts. What's going on, and can't get a good history.
So when
from.
do people normally come to you? Do they go through their primary care?
Most people go through their primary care. Yeah, and I think that does depend on their insurance. There are HMOs, PPOs still that if you get penalized, or you can't actually just go right to a specialist. You've got to be referred by your primary care doctor. But in general, if it's not like an injury that you went to the ER, because also if you fracture your ankle and you go to the ER, well, they'll send you right to me. They won't make you go to your primary care doctor. But if someone's had my shoulder's been hurting me for 6 months, it's not a bad idea to have the primary care doctor take a look at it. Yeah, and then say, hey, this looks like something that's simple, let's do this, and if it doesn't work, then go to, the orthopedic surgeon, and I don't mind just seeing those patients right off the bat anyways. Yeah.
Well, thank you.
Yeah.
For somebody who, has sent my mother to you and then my own niece to you, I appreciate the level of care, and as always, it's amazing what services and the level of services and dedication that we have here at the center of the universe in our new medical center. Take advantage of it. Become an informed patient, but go talk to your primary care if you have pains. Find out what options are open.
That's right, yep.
And as always, to our 6 loyal viewers, I hope you never have to see Michael here at all, but if you do, you'll be in good hands. May God bless. May tomorrow be a better night than tonight. Good night, all.
Thank you.
Not too long since I've been home.